Okay, so what I wanted to circle back with is we had spent a fair amount of time talking about how to set up your hospital's infrastructure to bring patients back for repeat intravenous therapy for skin infections and antibiotics. And you just blew it all up. They don't have to come back. Give them a dose, send them home, say, have a nice life.
That's right. That's right. That's right. But I still think that there are several different ways to use those antibiotics in a hospital setting. And hospitals would prefer to use them as outpatients because hospitals will get reimbursed for their use if used as outpatients. And I think most hospitals that do use those two antibiotics use them mostly as outpatients. And as outpatients, it can be either in the emergency department or in a wound center or an outpatient clinic. I still think that particularly for the emergency department, it's important to provide the ability for follow-up in the hospital setting. Because if you come with this wonderful program for the emergency department doctor and you train them, but then they call for a follow-up because they're concerned about the patient, and they say, I understand, you get the entire dose, but the patient doesn't have a primary care physician or whatever, and they call the wound center, they call the outpatient clinic and get an appointment in 3 or 4 weeks, they're going to be concerned, they may not do that, and they may admit the patient. So you need to take care of the infusion and you have to take care of the follow-up. Now, most patients don't need to be followed in a hospital. They can be followed with their primary care physician.
I think it really comes down to 3 things. I think it's finding the right patient, whether it's, have they failed outpatient oral therapy? Do they, allergies an issue? History of MRSA? Early recognition, so being able to find them a time before they're admitted. If they are admitted, finding them, getting them out of the hospital earlier, and then ensuring that proper monitoring and follow-up.
But again, I'm not saying lose them to follow, but I am saying you don't have to bring them back, put them in a chair, hook up another IV for another intravenous administration in 3 days. This is you give the antibiotic and you're done. It would be very nice if you followed up and made sure it worked.
Absolutely.
Right.
Absolutely. And we've seen great success rates with both agents to the point where we feel very comfortable using them for that reason, where you don't have to necessarily always bring them back, say, come back, call us if you have issues type thing.
All right, so give me a typical case.
I just, by the way, want to say, you may think it's a compromise.
No, I don't, but go ahead.
No, not you specifically, but when you give 1 dose versus, you could admit someone to get, 10 days of twice-a-day vancomycin, and you may think it's a compromise. In fact, each of those has a half-life that's so long that will go well beyond the 10 days of vancomycin. So in fact, this is a much longer course than the long course of vancomycin or what have you.
So even your heretical comment about stopping antibiotics early evaporates because this thing actually with 1 dose just hangs in there.
That's right.